This really falls, those of you who've been in the previous echo clinics that we've had with some of Dr. Smith's presentations, as well as one of my presentations. This really is sort of, I guess, would be the capstone of that. Sort of what do you do after you screen somebody and you've identified somebody's in a crisis, and then kind of what's the next step that you're going to do from there. So what we're going to do is detail the steps of crisis intervention and safety planning. The reason why I'm embedding safety planning and crisis intervention is it's not a standalone intervention. It really goes within crisis intervention. And then just talk about some of the best practice safety plans in diverse settings, including primary care, which was sort of my emphasis in the lit review. So crisis, really quick, stressful life event that overwhelms a person's ability to cope effectively. Essentially, the way that people think about it is that, you know, the individual, the adolescent has coping skills and something happens either developmentally or environmentally that affects their ability for those coping strategies to still work. And essentially, they feel overwhelmed. So crisis intervention is an immediate short-term help to those individuals. And essentially, you're trying to help them just get back to baseline, not necessarily to improve above their baseline, but just get them back to their sort of regular functioning. And a safety plan is a written list of coping strategies and sources of support that patients can use during or before the crisis. And safety planning has been identified as a best practice in primary care and related clinical settings. And we both, Dr. Smith and I both, have spoke about zero suicide, and specifically zero suicide in primary care and integrated care settings. And safety planning is seen as a key integral part of that entire intervention suite. So, oh, and by the way, some of you, like when I first got in the field in the mid-90s, we were doing the no harm contracts. So just to speak on that for a moment, the no harm contracts, there was some evidence to support that they were effective, though that evidence was very mixed. And really, many folks believed that it was, they weren't as effective because it was really focused on what the person's not going to do and what are some proactive strategies they could do to improve their wellness and make it less likely to have a full-blown crisis or bad outcome. So there began to be a shift in terms of the safety plans, which are less from what you're not going to do and more to what you are going to do. And they're perceived as more comprehensive. And there's not a ton of research yet with safety plans. And really, in the grand scheme of things, there's not a ton of research in terms of good crisis intervention, but safety planning has been highlighted as a emerging best practice and is seen as the best, more adequate way to deal with crises in these type of settings. So really quick, first characteristics of a crisis can be very subjective, and with adolescents is often related to peers or caregivers. So that's oftentimes for adolescents. It could be other things, obviously, but oftentimes the crisis stems from some sort of interaction with peers or caregivers. It can be from mild to severe. By nature, it's time limited. Can arise from seemingly negative and positive events. An example of that, I just had a woman at University of Akron who had received an accolade from her academic department, and she was so unaccustomed to being highlighted for positive things, she spiraled downward. And began to get suicidal after having this big success. So I think the point is that you can't guess or estimate or predict what's going to trigger somebody. And it's really important to kind of put your own values and beliefs behind and be attentive to the person. And another way to kind of think about crisis is it is an opportunity for someone to grow. Typically, that's when you have a crisis, people are confronted with different paths they can go on. So you can kind of couch it in a more positive way in that way. Like I said, they can be situational. And typically situational are sudden and unavoidable, not always though. So obviously a situational anticipated could be the loss of a parent or even a pet or a loved one. That could put an adolescent or young adult into a crisis. Unanticipated, natural disasters, things like that, or the sudden unexpected death of a loved one. Or obviously the victim of some sort of violence or bullying. It can also be developmental. So things that are more predictable, like entering puberty, going to middle school, going to high school, going to college, leaving home. Some of you work with kids who are in out-of-home placement. with child welfare, so they've been removed from their home. Obviously, that's another crisis situation, or could be. And essentially, what are characteristics of people in crisis? There's oftentimes a real challenge with problem solving. If you kind of think about it, they're oftentimes so aroused emotionally that it's hard to really attend to more of that sort of executive functioning part of their cognition. So it's harder to plan and think through what the consequences are going to be of certain actions because they're so aroused. Like I said before, they may have had effective coping in the past, but that coping may no longer be effective for the current situation. Oftentimes, you're going to see lower level functioning at school and at home and relationships. Like I mentioned before, it can be hard to process new information, and you might notice a really short attention span, like a really hard time sort of attending to something in any great length. People oftentimes talk about stress, right? So stress, nerves, some communities may just talk about nerves. I feel nervous, I feel stress. There may be symptoms like anxiety, sleep or eating problems, headaches, GI complaints, feelings of helplessness, and substance use. So what are you trying to do? Essentially, you're trying to establish immediate coping or problem solving to really get the person back to baseline. You're trying to provide support, reduce lethality and harm, linked to helping resources. And something to keep in mind is that oftentimes when people are in crisis, they're the most open to considering a change. So it's a real opportunity to help someone really evaluate their life and decide to make a different decision. And oftentimes it's kind of like the idea of someone's hit bottom. When someone's in crisis, sometimes they've hit bottom, and therefore they might be more motivated to do something different. So it really is like that kind of strike while the iron's hot type of philosophy. When you're engaging in beginning to do the crisis intervention and the safety planning, you want to, in general, ask open-ended questions, use a lot of reflections to let the person know that you're hearing them. And it's also helpful for the person because they're so stimulated, sometimes they're not exactly sure what they're saying and how it fits together. So doing summaries and reflections can help them have a more clear narrative of what's going on. Clearly, non-judgmental content and tone, like if I were, for example, that woman on Wednesday, if I'd have been dismissive and in some way sort of suggested, why in the world would you be upset when you had this really big accolade from your department? That could be perceived as really judgmental, right? Like I'm telling her she shouldn't have felt how she felt in that situation. So it's really important to just be attending to the person and to try and understand from their perspective what's going on. Talking with and not to, so this is a time to not be particularly directive. There is a certain situation we'll talk about when you might want to be more directive, but in general, you're trying to relate and not direct somebody to do something. I mentioned before, assume and presume nothing, avoid labeling, and listening is really important. So here's some steps that have been highlighted in primary care in a variety of settings for dealing with crisis intervention and then developing a safety plan. So defining the problem, first of all, and helping the person just sort of understand what were the events that led to the crisis and what is the problem. So for example, the death of a pet, and by the way, my kids just experienced the death of pets, that's why it's on my mind. The death of a pet may be the event that produced the crisis. So the kid may have been very close to this pet, it was their sort of support animal, and then when that pet passed, that could be sort of the trigger for the crisis. But the problem would be then they have a depressive episode based on that, or they're considering non-suicidal self-injurious behavior to address that issue. So the problem is really what's the ramification of that trigger. Ensuring patient safety. So if it's an imminent risk, you're going to be doing something different, which we'll talk about, rather than if it's not an imminent risk and you're not concerned that there's an imminent risk the person's going to hurt themselves or someone else. For the ensuring patient safety, you might want to use more closed-ended questions. For example, if you're doing a physical assessment and you have there's something, a physical mark on the child, there's some bullying, you might want to ask specific questions. Did your brother do that to you? Did your mom do that to you? Did your mom do that to you? Because in that case, you're trying to gather information and you need really a clear answer. Sometimes you might have people in your office that are currently a victim of sexual assault or child abuse. So questions like, are you safe right now? And you can ask the parents to leave the room for a few minutes. You can talk to the child on their own. For a suicidal patient, evaluate the immediate need for danger and for intervention. So you're really trying to figure out what is the risk? Is it imminent? Are the people who are perhaps perpetrators involved in the child's life right at that time. Providing support, so you want to communicate you're concerned about them. I don't know how many times I've had this happen where I've seen a provider tell someone, we're really worried about you potentially killing yourself, and then the person might say, you're just worried because you're going to be liable if I do it. So I think it's really clear to say that you're concerned about the person and you want what's best for them, because it's really easy for them to dismiss sort of what you're saying. And affirm the strengths that you see. The woman I saw just last week, I affirmed, like, wow, it is so courageous. You're showing such strength to come in here and say what you just said to me. So you can oftentimes affirm the strengths that you're seeing and be specific and genuine. So number 4 is examining alternatives. And again, and I'm not going to focus on the imminent risk as much because Doug really has covered that in a couple of weeks. But if someone's at imminent risk to kill themselves or someone else, or serious bodily harm to self or others, you're not as much looking at alternatives at that point. You're then trying to figure out pink slip, 911 call, basically getting them an involuntary hospitalization if they're not willing to go. But taking that off, if they're not an imminent risk or don't appear to be, you want to explore the options the person has available. What type of ways can they think of to deal with this crisis? Help them think through people who may support them and be helpful to them. Identify coping strategies, possibly something that worked in the past that they've kind of forgotten helped. Now, making a safety plan. So it should be collaborative with the clinician and individually tailored for the patient. So a safety plan is very collaborative, and you'll see an example at the end. You want to focus on existing support and provide 24-hour backup, because often, obviously in most of our settings, we're not there all the time. And crises oftentimes happen in the middle of the night when someone's all alone and trapped with their own thoughts and their own 4 walls. So you really want to give people the opportunity and resources for 24-hour help and assistance. Include 1 or more reasons the patient has identified for living. We call those protective factors. But like, for example, the woman I saw Wednesday, who she was contemplating suicide earlier in the day, was no longer imminent risk. I was asking about it, and she really wanted to be a role model to her younger sister. And she was pursuing a career her younger sister's interested in. And as well as she identified as Catholic and had beliefs about what would happen if she killed herself being Catholic. So those were 2 protective factors she could identify. Plan should provide patient with positive action steps. So for example, the person I saw recently, part of her action steps was she has a woman in her dorm with a similar faith background, and she was going to make more of a strong connection to this person who they've helped each other out to be kind of a person she can speak to. They can read scripture together if she begins to get triggered. And the plan should be consistent with the level of functioning, congruent with goals and values. Like I just mentioned, my person identified as Catholic, so we were trying to look at things that fell within that, and including important others whenever possible. Safety plans are endorsed by the Department of Veteran Affairs and are accepted as best practices, as well as there's a big review of sort of addressing suicide in rural primary care settings. And the safety plans were also seen as more effective in that setting than the no harm contracts. I have a resource there where you can get blank safety plan templates if you like. And finally, so the 6th step is that you would ask the person to repeat back his or her plan. And that's just sort of a way of ensuring that the person's in agreement with doing these proactive steps. Again, they're not agreeing not to kill themselves. What they're agreeing to do is to do these other steps in order to make it less likely they would do that. And these are my resources. I'm going to pull up an example of a safety plan and just walk through it really quickly. So bear with me 1 minute, and you'll get a copy of this plan too when we send you okay. So you can see the one thing that is most important to me and worth living for is blah, blah, blah. So that would be, my religious faith is incongruent with killing myself because I believe this would happen. That would be an example. So warning signs. So the person I just saw, it could be feelings of success, feelings of a lot of unwanted attention, as well as just being an introvert and all of a sudden an expectation that you're going to be a public face of an organization. Internal coping strategies. So This, the person may have learned some mindfulness techniques in the past. So that might be something they decide to try and do. Another person may have found that baking. I've had someone where baking muffins was actually a coping strategy. Again, not to be judgmental. If that works for somebody, that works for somebody. Physical activity, exercising. So those are, so you're helping someone think of what are some things they can do on their own. And then your step 3 is helping people think of perhaps people they could call. So, the woman I just mentioned, she had the name of the person from her dorm. She had the person's phone number. And the idea is it's all really accessible. So when you're frantic and in crisis and perhaps forgetting about these things, it's right there, easily accessible with all the information that you need. Step 4, same thing to some degree, people who I can ask for help for, and names and phone numbers. Number 5, professionals or agencies. And I put in this one, the Ohio 24-hour crisis text line, which is 24 hours, 7 days a week, free. Obviously, there's a suicide prevention lifeline, which is also 24/7. Put the 911 number down. Sometimes people would put the therapist phone number down, the physician, nurse, whoever the contact is for their integrated healthcare needs. And then finally, step 6, how can I make my environment safe? So, clearly if you have a young person who has access to a gun or access to knives that they could use, part of what that might be is them and the family getting together and putting those in places where the person can't get access to them. Because we know that is actually one of the best practices that we can adopt, is to help people make their environment more safe so that those lethal means are less accessible. So that's essentially sort of the process. You'd go through that with somebody. You'd make sure that it was congruent with what they thought would be helpful. And like I said, you might ask them to repeat it to make sure that kind of it makes sense to them and it makes sense to you. And with that, that's the gist of my safety plan discussion.